Thank you everyone for joining live. Um, so this is part 3 of 6-part series brain injury basics course. And this part is specifically discussing brainstem rehabilitation. So if you remember from the first talk that I did, the way that I approach brain rehabilitation is I think of our nervous system as a home. And the reason for that is it's just the way I see it in my head is when the brain
When the
get
brain
let me if you guys can just mute when you come in. When the brain gets injured, there's some foundational things that need to be addressed in order for proper brain healing. And this is just from what I've learned in the clinic and things that I've seen help patients. So today we're talking about the foundation of the home. And again, the reason for this is the way that we neurologically develop, the way that the big part of our brain develops is from the bottom up and from the back to the front. So our main focus is going to be here today. The next talk next month, it'll be discussing the cerebellum and the vestibular centers because the cerebellum is essentially an outpouching of neurological tissue from behind the brainstem. So it's intimately connected to brainstem areas. So in a sense, when you're doing brainstem rehabilitation, you're probably getting some collateral stimulation to the cerebellum, especially with some of the exercises that I show you here. But it's a really important part to rehab because the cerebellum, it's the little brain. I say it's the little brain with a big impact. If you do cerebellar exercises, you can actually change the way other areas of the brain work more efficiently. So just like a home, uh, the foundation comes first, and in our nervous system, the brainstem is that foundation. This is just from me working in this space for several years and um, trial and error and trying to help patients who have had mostly suffered like severe brain injuries. But I also think that this relates to patients who have had mild concussive symptoms from what are diagnosed as like a mild TBI or concussion. So when a brain injury occurs, it's almost like a thunderstorm or a tornado comes through and it just totally wreaks havoc on the home. And it creates in my the again, this is the way that I see brain injuries. It creates a crack in the foundation of our nervous system. Our therapy is not considered traditional therapy. In a sense, it's not, we're not doing just strictly physical therapy or occupational therapy or speech therapy. The way that we do therapy in our clinic is I always ask the question, where was the nervous system injured and what does the nervous system need in order to be its best self, in order to be the best nervous system? And I think it all starts with the brainstem. So we have to reestablish a strong neurological foundation via the brainstem. And there's 3 strategies to doing this. And I think with brain injury, the first strategy is getting a little bit hyper focused on how the autonomic nervous system is functioning. So when we're neurologically developing, kiddos, babies, they're typically more in a sympathetic dominant state. And it's mostly because they haven't developed the inhibitory neural networks to balance out autonomic function. As the brainstem integrates within the first year of life, and then the other areas of the brain start to grow and grow and get stronger, then there becomes an inhibition of sympathetic output. And that looks like clinically more parasympathetic tone, more vagus nerve function. So there's better balance in autonomics as the brain grows. Now, when there's a brain injury, let's say someone has had a completely neurotypical life, they've never had an injury, they've lived 30 years of their life completely head injury free. And then all of a sudden, there's this shock to the nervous system, there's this injury to the brain. What can happen is it can take you all the way back to that first year of life, and it can rock that foundation, and it can shut off those pathways where the brainstem and the brain are supposed to be working inherently together. So and you can see this in an extreme case, like in an extreme case of brain injury, there can be what's called neurostorming. I don't know if anyone's had a family or loved one that's experienced that, but it's really scary. And that's when the sympathetic nervous system just goes bananas, and there's no counterbalance. There's no parasympathetic flow that's coming in to kind of balance things out. So when there is a brain injury, I think one of the first things that needs to be addressed is looking at autonomic function, and there's specific ways to do that. But even if you're not doing clinical testing to look at HRV levels, heart rate variability levels, or signs of sympathetic distress or signs of lack of parasympathetic flow, you can start by doing some simple stuff to help try to feed the parasympathetic nervous system to balance out that imbalance. And the reason I say this is because the whole goal with neurorehabilitation is to build positive neuroplasticity. And it's very difficult to build positive neuroplasticity when people are stuck in a stress state. It's really, really hard to build neuroplasticity in a stressful environment, whether that's an internal nervous system stressful environment or an external. So in order to build neuroplasticity and positively change the brain, we've got to provide sensory stimulation that's going to promote increases in parasympathetic function. The way I do that in the clinic, just to break it down in three simple methods, is through two cranial nerves, the vagus nerve and the trigeminal nerve. And then I also began using guided meditation. Uh, I mostly use guided meditation because some of our patients, they've never meditated before. It's really hard to get in a sort of meditative state. So we use a device called the BrainTap, which I'm sure a lot of people are familiar with. But I really like it because I used it on myself for a while before I started using it with patients, and I think it can really help. So step one is vagus nerve stimulation. And I know that, that's my thing. Like I'm going backwards here. That's the thing I talk about a lot on social media, but it's still relatively new. And the way that vagus nerve stimulation has come about in the neurology space is it's helped people, and implantable vagus nerve stimulating devices were initially brought to market because the research showed that it helped reduce seizure activity in medication resistant patients, epileptic patients, upwards of 50%, which is pretty huge. They can modulate the nervous system to reduce seizure activity. Fast forward, now everyone's looking at transcutaneous vagus nerve devices because they're better, they're less expensive, and they can help a lot more people. So using vagus nerve stimulation can help promote parasympathetic function. And if that's all I'm looking at for this is, can I do something to help increase parasympathetic function and reduce sympathetic function? That's all I'm looking to do from this regard. That's all I want to do, right? There's so many other things that the vagus nerve does, and there's so many ways to do vagus nerve stimulation. But the vagus nerve is it's like a huge highway of communication that can improve parasympathetic nervous system function with simple stimulation. Sorry, I'm just going to mute everyone that's coming in. Okay. Oh, let me go back. I just want to read these to you because I try to include research here to just show people what the research is showing. So the efferent function, which means from brain or the central nervous system to body, a vagus nerve primarily modulates parasympathetic nervous system function in the peripheral system, which means the body. So it acts as a counterbalance to the sympathetic nervous system. That's huge, right? If we can shift a brain that's been injured into more of a parasympathetic state, then we set the stage for neuroplasticity to occur. That's the main reason to do vagus nerve stimulation. From this paper, our results from traumatized subjects without PTSD demonstrate decreased sympathetic and increased parasympathetic tone during transcutaneous TCVNS, vagus nerve stimulation, following acute traumatic stress, suggesting possible translation of this treatment to patients with PTSD. And VNS improves autonomic dysfunction, reducing sympathetic and enhancing parasympathetic tone. So I think if there's a practice in brain injury where we can feed that foundation of the nervous system and just stimulate the vagus nerve to get things back in line, then again, you just create that nice stage for neuroplasticity to occur. The way we do it in our clinic, and again, there's several ways to do it. This area right here. This is known as the Simba concha. It's just an area of the ear. It's heavily researched in transcutaneous vagus nerve stimulation. Right below the ear, there's a branch of the vagus nerve called the auricular branch, which just means the branch of the ear of the vagus nerve. It wraps around down, kind of following what's called like the SCM, your sternocleidomastoid muscle. So there are cervical transcutaneous vagus nerve stimulators, but if you have access to a device that can stimulate the vagus nerve, it's a gentle electrical impulse on the Simba concha that, and this is the way I see it in my head, it starts to light up the auricular branch of the vagus nerve, but it has a lot of central properties. So it goes into the brainstem, and then it starts to stimulate the projections of the vagus nerve that go into the brain, and then the projections that also go to the rest of the body, because it's a huge wandering nerve. In the clinic, I typically couple it with photobiomodulation therapy. Not to say that when you use light, you directly stimulate the vagus nerve, but the way I understand light therapy to work is that you can improve mitochondrial function of cellular activity when you shine specific wavelengths of light on different areas of the body. And there is research to show that photobiomodulation can regenerate damaged peripheral nerves, such as facial and trigeminal. I haven't found a paper on vagus nerve yet, but it can regenerate peripheral nerves and improve what's called axonal flow, which just means it can improve the communication of the nerve fibers to and from, it's really cool. And when you couple a vagus nerve stimulation with electric devices and then add in a light therapy device, I think what you're doing is you're further setting that stage to receive the input better. So you're improving cellular function, you're improving ATP production, improving mitochondrial function. Whatever job a cell has to do, it can do it better now. So if that cell is responsible for feeling and talking to the vagus nerve, then it can do it better. So that's why I'll typically, when I write a protocol for a patient, we'll do vagus nerve stimulation. If they have an electrical device, I'll have them use the electrical device, but I'll have them follow with a red light device or a laser device just to improve overall function. And I've had good results with this. In a couple of different settings, obviously improving parasympathetic tone, but then also reducing seizure activity. The occurrence of seizures, so like the time span between actual seizures, and the severity and the time that a seizure lasts. So it's always crazy to me. I've said this before, but when I first learned about the vagus nerve in school, you learn it for boards and you're like, okay, it helps you like sleep and poop, but which it does. But when you have a brain injury, it really helps just shift the body out of that fight or flight sympathetic tone into parasympathetic tone. So vagus nerve stimulation is part one. And I'm going to talk about like what a therapy session would look like in a little bit. The second nerve, this is a little bit newer for me, but it's starting to come out in the research a little bit more now, is the trigeminal nerve. A lot of research on trigeminal nerve has been helping with patients who have jaw pain, or it's called tic douloureux trigeminal neuralgia. But stimulating the trigeminal nerve is actually, it can be very, very profound for brain function. And I posted about this, but it can improve brain blood flow. It can improve blood-brain barrier integrity, but it can also help, just like the vagus nerve does, it can help balance out parasympathetic versus sympathetic tone. Again, The first goal with this in creating a smooth foundation is brainstem stimulation to change autonomic function. We want to create an internal environment that promotes the ability for neuroplastic change. And you do that by shifting into a parasympathetic state. So just like the vagus nerve, efferent, which means brain to body, trigeminal signaling feeds peripheral and central parasympathetic activity through an area in the brainstem called the NTS, the nucleus tractus solitarius, and the DMN. I forget what that stands for. Dorsal motor nuclei, I think. Anyways, it teams up with the vagus nerve, according to this paper, recruiting the vagus nerve, which modulates cardiac performance and systemic inflammation. Obviously, when you can balance out autonomic function, improve parasympathetic function, you can also hopefully reduce systemic inflammation and neuroinflammation, which are also a common metabolic side effect of a brain injury. So that's pretty neat. This paper was cool. I'm more of a right brain person, so sometimes it's hard to really stay focused. Oh, dorsal motor nucleus, there it is. There's my focus. To really stay focused on lots of words, just like when I get like a really big email, I'm like, oh my God, just send me the Cliff Notes version of this email, please. So I saw this paper and then it had this great picture. And the picture, you can read all about it. I'll make sure I share these slides. But within this paper, this picture showed that there's three mechanisms of transcutaneous trigeminal nerve stimulation. There are three main categories. One is the release of vasoactive peptides, which is it's going to help modulate parasympathetic versus sympathetic tone. The modulation of neurotransmission via neurotransmitters, things like acetylcholine. So that's also going to help modulate the flow of parasympathetic versus sympathetic state and modulation of the autonomic nervous system directly. So there's indirect and direct consequences of stimulating the trigeminal nerve. And you can read all about it here. But some of the things I made this post while I get bored like making presentations. So then I'm like, oh, I'll make this into an Instagram post. But some of the neuroprotective effects of trigeminal nerve stimulation from this paper down here, whenever I do a post, I try to add in the DOI so you can look it up if you'd like. Improved brain blood flow, improved blood-brain barrier function, which if you're not familiar with the blood-brain barrier, our nervous system, our bodies have barrier systems. We have a skin barrier, lung barrier, gut barrier, brain barrier. If the blood-brain barrier gets disrupted, it's almost like somebody broke down the fence and it can now come in and tear up your yard. Let me hit admit real quick. So yeah, I really liked this was a cool paper because it just talked about all the other things besides helping balance out autonomic function. Trigeminal nerve stimulation can improve brain blood flow, which I've read papers in traumatic brain injury where concussion, TBI and TBI and MTBI, there can be a reduction of blood flow to the brain upwards of, again, 50%, which means that you're not getting oxygen to the brain. The brain is a gravity dependent peripheral organ, which means that we have to have adequate blood flow, so pumping from the heart and recycling from muscular tissue to get proper blood flow to the brain. So if we can improve brain blood flow, we can improve oxygen, we can improve cellular function, and then we just have a better brain. So improve barrier function. So someone goes in and repairs the fence, reduce brain inflammation, reduce brain swelling, and then increase nerve growth factors, which again sets the stage for neuroplasticity. So what that looks like in the clinic, just like with vagus nerve stimulation, it's a pretty simple application. You can use different devices. You can use a vibration device. We use the Resimax for vibration in our clinic because it's got the two blue wings that you can just clip right onto the middle part of the trigeminal nerve. But the trigeminal nerve has three main branches that stem from right outside, I'll say the ear hole, your external auditory meatus. But right in front of there, you've got like a main branch of the trigeminal nerves, and they go up over the eye. That's the ophthalmic branch. under the eye towards the nose, that's the maxillary branch. And then down by the jaw, that's the mandibular branch. So I'll typically stimulate the trigeminal nerve right on the cheek. And it's a light impulse. The patient will say they feel it. It feels a little bit weird. You might see a little bit of flicker of their eyebrow or some flicker of their nose. And again, I couple it with photobiomodulation therapy because I think that it's going to help improve cellular function, which could hopefully improve clinical outcomes. And it's not too hard. So it's not hard on the practitioner or the patient. It's a simple application with some profound impacts on the nervous system, just as you've seen in the research. Again, trying to balance out parasympathetic flow. What did I want to say about this? Oh, so I'll usually do a brainstem stimulation circuit. So I start with the Simba concha. So I'll stimulate the Simba concha for vagus nerve stimulation. From the Simba concha, I'll go to the trigeminal region, and then I'll do the same thing on the other side. So I'll kind of do a little circuit on the face to help improve parasympathetic output and balance out parasympathetic versus sympathetic issues. So the last part of part one of stimulating the brainstem, I use meditation. I'll typically save this towards the end of a session with a patient. I like to end with this. I started using this in the clinic 4 or 5 months ago, and I had used it on myself for a while, the BrainTap device. And I like it because if the patient can tolerate it with the visual stimulus and the auditory, the binaural beats that it uses, I just really like the way that I feel after I do a BrainTap session. You don't have to use a BrainTap. You can also have a patient do like a guided meditation. I'm sure like there's actually people that are listening to this that are way better at meditation than I am. But I use the BrainTap, and I'll show you how we use it in the clinic. Dr. Patrick Porter, he's the brains behind BrainTap. He and his father, they had some poster presentations during the pandemic. That's when I started following them because I was stressed out and I was like, I need to do something to balance out my autonomic nervous system. So I started using the BrainTap. But this is a study on 100 adult volunteers. And the goal with this was to see how it would help improve heart rate variability. Just to let you guys know, so I had a patient in here yesterday. They were told that they have a low HRV. Typically, what that means is if you have a low HRV, a low heart rate variability, you're going to have low vagal tone, which means your vagus nerve isn't firing as well as it could. What you would like to see is a high HRV. High HRV means you have improved parasympathetic function via the vagus nerve. So, in their study of 100 adult volunteers, they found that one single audio visual brain entrainment session using the BrainTap device increased heart rate variability and improved parasympathetic activity and decreased stress index and heart rate, which, sitting and resting in a quiet room can also do that. But I think there's some really neat stuff behind the BrainTap. And if you've never met Dr. Patrick Porter, like it's funny, he's such a nice guy. But when I first heard him, I didn't know who he was, and I imagined like with his deep voice, just like I imagined like a burly guy like that owned like a brewery or something. And he kind of looks like that. He's like got a big beard and just a super nice guy, super smart, and he's an amazing person in the neuro rehab space. So if you're not familiar with this device, I really like it. I think it's worth checking out. And what it looks like in the clinic, I just want to show you. My wife's going to kill me for showing this picture, but this is a cool story. So we have three boys. Our third boy was due October 28th, a week before I was supposed to do a half Ironman competition. So I was going to try to go to the event, but then, I was like, maybe I shouldn't, because it was like 7 hours away. So, anyways, let me go back. My wife came in on a Thursday, to the clinic, or she was texting me. She's like, hey, I'm kind of stressed out. It's busy. Life is so busy, and I always just freak out with stress. I think stress can just like shut systems down, yada yada yada. So I said, hey, come into the clinic and let's do a brain tap session. This was on a Thursday, a week and a few days before our third boy, his name's Crew, baby Crew, is due. So she came in and she never, she's always just she's so busy on the go. She works. She's a physical therapist. She also takes care of three little boys and one big boy at home. So she's an incredible human, but she never sits down and takes care of herself. So I said, come in, let's do a brain tap session. So the way we do brain tap sessions in the clinic, we use the Nano V. I really like this device. I can go into detail about it later. I tell kids that we laser their boogers with it, but it's vaporized distilled water using light frequencies, and you breathe it in through a nasal cannula. It helps with oxidative stress, mitochondrial function. So we hook up the patients to the Nano V. I usually will put lasers on the cervical area of vagus nerve, or I'll do it on the carotids to improve brain blood flow, and then get them comfy in a like lounge chair thingy, and then do the brain tap session. So she's always spot on with her pregnancies, but I think that she was so relaxed. The next day, we ended up having baby crew, and just shout out to her. She's like three boys, all natural. No idea how she does it, but I think the brain tap put her into such a like she got up from it, and she was just, you could tell she was so well rested from like a 20-minute session. And then the next day we went and had a baby crew. So that was that's my cool brain tap, parasympathetic, have a baby story. Okay. Step two. This might be a weird one. People may have not have heard this before, but I think there is some true science to this. And I think that this is a missing piece in traditional neurological therapy. And that is to assess and remediate retained primitive reflexes. So again, our focus is on the foundation of the nervous system. Primitive reflexes, which if you're not familiar with them, let's just go into them real quick. The ones I'm going to talk about just based on a research paper: the Moro reflex, ATNR, STNR reflex, the TLR reflex, tonic labyrinthine reflex, and the spinal gland reflex. I want to talk about primitive reflexes because they live in the brainstem. And if there's a brain injury and the foundation is disrupted, then I think that there is a change in the way that the primitive reflexes may re-emerge. Because what primitive reflexes are, they are our involuntary motor responses that originate in the brainstem. They're present after birth and in early childhood, and they're there to help us through survival. They're basically survival reflexes. They're very important. They're central nervous system motor responses. They're typically inhibited within the first year of life. I think 4 to 6 months that's pretty fast. Usually, from what I know, it's within the first year of life, but they become inhibited as the brain matures. And when the brain matures, it replaces these involuntary motor responses with voluntary motor responses. But they can return, so they can reemerge. I say they come out of hibernation, right? Because after a year of neurotypical development, primitive reflexes, these involuntary motor responses, should go into neurological hibernation. And the reason they should go into neurological hibernation is to allow for cortical maturity, further brain maturity. They can return, or they can reemerge or come out of hibernation if there is neurological injury. And if they do reemerge, what I think that does is it will create a speed bump in further brain development or brain healing, right? Because if we're talking about an adult patient who's had a brain injury, they had that normal neurotypical development, lived 30 years, no problem, boom, they had a brain injury. I think one of the first things that should be assessed after we look at balancing out the autonomics is primitive reflexes. You have to see if they've come out of hibernation. And the reason for that is, if you're taking an adult patient and you're trying to rehabilitate, or a kid who's like 4 or 6 because they should have been in hibernation at that time, and you're trying to rehabilitate the big areas of the brain, it's going to be hard to do if those reflexes have reemerged or if they've come out of hibernation. The way that they go into hibernation is through environmental enrichment, normal neurotypical development, but there are stereotypical exercises that you can do to put them back into hibernation if they reemerge. So in brain injury, primitive reflexes should be assessed and then remediated before maybe going into trying to walk normal again, right? Because the way that we learn to walk is crawl. Before crawling, we learn postural control, sitting up, head movement, keeping our head up, stuff like that. So I think you have to take it a step back. Like we've had patients who plateaued in traditional therapy. They've done traditional therapy for a year after a brain injury, but they're just not making gains. We do an assessment of their primitive reflexes. Their primitive reflexes are present, even though they may have been gone before the brain injury happened. We rehabilitate the primitive reflexes that have come out of hibernation, and then all of a sudden, the traditional therapy starts working better and better and better, and they start making gains. So it's pretty neat. There's a good book on this, Dr. Robert Malillo. He wrote a book called Disconnected Kids. You can learn more about it. He doesn't necessarily talk about brain injury in there, but you can learn a lot about primitive reflexes, how to assess them, and then exercises to do for them. I did my best to show you some videos of how I do it in the clinic, but if you're interested, you can check that out. So this is a paper I came across because I I forget where I heard this. I was at a conference and someone said, if you're working with brain injury patients, you should look at their primitive reflexes. And it immediately was like, oh, it was kind of like one of those dang, duh moments, that was a few years ago. But it makes a lot of sense to me. And what this paper found was that, if you can see it up here, these are primitive reflexes associated with brain injuries and visual deficits. Moro, which is our fight or flight response, it typically integrates within the first few months of life, but if not, the patient could have balance and coordination issues, trouble with sleeping, trouble with vision, difficulty reading or writing, neurocognitive fatigue, body fatigue, impulse control. And that all could be from a persistent or an uninhibited or reemerge or out of hibernation primitive reflex. STNR. So this helps us with crawling. It does play a role in postural muscle tone, hand-eye coordination, which can also be seen in a brain injury patient. ATNR, difficulty with hand-eye, crossing vertical or midline, visual tracking. Spinal galant, postural deficits, fidgeting, difficulty with bowel and bladder function, issues with memory, all associated with a retained spinal galant reflex. TLR, tonic labyrinthine reflex, balance, eye tracking. So lots of things that we see in patients who have symptoms after brain injury. So it would make sense to learn some exercises. It would make sense to learn how to assess to see if they're there, which I don't go over in this lecture. But it would also make sense. Let's just say that you've got a brain injured patient. Well, let's just give them a set of exercises to do that would put those primitive reflexes back into hibernation. So these are some videos that I came up with to show you that. How I do remediation exercises for oral reflex in the clinic. The patient who's had a concussion or a brain injury and they're physically able to do it. So I use a Bosu ball to promote extension. And the way we start is we start with rights over lefts in flexion. So kind of like in that flexed fetal position, but right arm over left, right leg over left leg as well. And I ask them to slowly go into starfish extension while they're inhaling through their nose to promote better nitric oxide production, and go into real full extension. And once they're there, they slowly come back in, crossing opposites, so lefts over rights, while they're exhaling. And I ask them to do up to 10 reps, possibly 2 to 3 sets, once or twice a day. So there's a few ways to remediate the Moro reflex. I like the starfish. I usually always try to incorporate some sort of breathing method. I'll also use a metronome to play in the background for timing and sequencing. But usually when I have patients do this, if they're physically capable of doing it, we work on inhalations during extension and exhalations during flexion. Inhaling through the nose because you can improve nitric oxide production, and then exhaling with a hum out to improve vagal nerve function. But that's a really simple, good exercise to do. And it can, again, put that moral reflex, if it's reemerged or come out of hibernation, back into hibernation. This is the next one. I kind of came up with this one.
Exercises that we work on, if the patient's physically capable, is remediating the ATNR primitive reflex, the STNR primitive reflex, and the TLR. And I kind of created a little combo exercise for that, again, if the patient is able. So they look like what would be called bird dogs. We have the patient get in the quadruped position, and we're going to do a cross crawl exercise with head turns and gaze stability. So I ask the patient to slowly extend their right leg and their left arm simultaneously with their left thumb sticking out. Now they start in the neutral position, but as the extension occurs, I have them turn their head towards the side of extension with their eyes focused on the tip of their thumb. Then they come back in and we do one STNR, kind of like cat-cow reflex, where I have them do flexion of the neck and extension of the neck, back to neutral, and then we switch sides. Then we go extension of left leg, extension of right leg, with right head turn, eyes focused on the thumb, and then back to neutral.
Right arm, not
and
right leg.
flexion of the head, extension of the head, boom. And that's one rep. And we go through about 8 to 10 reps, 2 to 3 sets if possible.
I posted, yeah, legs and arms. Get those mixed up. I posted quite a few videos of one of our local patients, Josh. He had probably one of the worst brain injuries I've ever seen. And he is a shining example of, he did all the right therapies, like, and he still does. He works with some amazing PTs, OTs, speech therapists, but he was starting to plateau. So one of the first things I did when he came into the clinic several months ago, I immediately, we looked at all of his vitals, sympathetic, parasympathetic. Then we just started with primitive reflex, and like, it's simple exercises, but his biggest issue was he was plateauing on what's called a Berg score. It's a balance test that they do. And he needed to get a certain score and he just couldn't get there. And all we did was this simple stuff. We did cross crawl exercises, postural exercises, simple balance exercises to integrate the primitive reflexes. His walking got better, his balance got better. It was really cool to see. And it didn't take a long time. It was almost like, the way I think about this is, you've got a highway, right? So you got a highway for better brain maturity, but there's a couple of potholes. You can still drive on it. The driving is just not as efficient. As soon as you do these exercises, you essentially fill those potholes and you have better, faster transmission. And so it kind of like breaks that plateau. And I truly think that's what doing primitive reflex remediation exercises in brain injury does for the brain. It just paves the way for cortical maturity. So the brain can be its best self. Because that's the goal with brain rehabilitation. You've just got to try to make the brain the best that it can be. Okay, so that's that one. And then one more. I'm sure you guys know all these. That's a little that's just one that I've come up with. It can be a little difficult, but
These are snow angels to help spinal column reflex, brain injury, or concussion. So there's a couple different ways to do this. In the clinic, we'll modify these if the patient tolerates. We'll add in electrical stimulation to the paraspinal muscles. We may also do these on a vibration plate if possible. But the simplest way to do these are steady and slow. You start in the pencil position, and then whenever I'm doing extension, just like in Moro, we'll have slow inhalation through the nose, making a snow angel, and I have the patient go all the way to the top, and then we go all the way back down and exhale. I always like to incorporate some sort of slow inhale, slow exhale breathing exercise during these, because we're really trying to stimulate the brainstem parasympathetic response. Doing these on different textures. So if you have like a shaggy carpet at home with no shirt on, then you're going to increase stimulus to the back muscles and you're going to increase stimulation to the brainstem. If you live in colder climates and you're brave enough, you can get some cold exposure by actually doing these in the snow with a thin layer of clothing on, or if you're brave enough with no shirt on. So really good exercise to help stimulate the spinal column reflex.
Yeah, that was just, I'm all into cold exposure now just from stuff I'm reading. So we just don't get a lot of snow in Atlanta. So that's why I said that. But that's a simple exercise to do. And like I said, you can modify it. I always try to improve, like I try to, like this exercise, what it could look like is we could have visual stimulation, which I'll talk about in a second. We could have the electrical stimulation on the back. Sometimes I'll have the lasers just shining on the cerebellar region to improve that mitochondrial function and cellular energy, et cetera, et cetera. So there's ways to co-stimulate or co-activate the nervous system when you're doing an exercise.
Hey everyone,
I'll get to the next slide here. Okay. So that's step two. So step one is balance out autonomics, vagus nerve stimulation, trigeminal nerve stimulation, some sort of top down guided meditation. Step two is assess and remediate primitive reflexes. I didn't go over how to assess, but if you just assume based on that one research paper that these primitive reflexes will be present in a patient who has had a mild concussion or brain injury, maybe doing some exercises to stimulate them can improve clinical outcomes. Step three is assess and stimulate other important cranial nerves. The way I do that is we'll use visual stimulation, eye movement or head movement stimulation to stimulate the eyes, because a lot of the muscles of the eyes, they get their information to and from the brainstem region. And then last but not least is taste and tongue stimulation. That's another one that I'm kind of going down a rabbit hole on, is electrical stimulation of the tongue. So I'll talk about that briefly. But the first is a device that I use that I just like because it's a simple wearable device. And the guy that developed them, his name is Peter Gillet. He's a chiropractor who knows a lot of neurology. So they're really, really cool device, and they're not crazy expensive. So they're simple to use. Kids tolerate them pretty well. But I use them in the clinic. Let me go back. Sorry, I'm moderating and flipping through at the same time. So I use them in the clinic for a couple of different reasons, mostly to stimulate the visual center. And the reason for that is there's research to show that the visual center, or there's visual dysfunction up in upwards of 90% of people who have suffered from a TBI. It's our major sensory area of the brain in people who can, in sighted people, so people who can see. And it's also a great area to get some co-activation to for the brain and for the brainstem. So these are just wearable devices called eyelights. They come with different colored lenses for hemispheric integration, but the way our visual system works from a brain perspective, not a brainstem perspective, is lights shining in the left visual field. I'm sorry, this is my right. In the right visual field will travel over to the left hemisphere, and lights shining in the left visual field will travel over to the right hemisphere. That's what I was trying to show with these arrows here. Uh, but you're also getting a lot of brainstem stimulation when you use light exposure. And the reason for that is you're getting releases of neurotransmitters. So two neurotransmitters in particular. One is dopamine. It's critical for brain function, for motivation, for drive, but also for physical movement. And that comes from the top part of the brain stem. It's called the midbrain. There are specific areas where dopamine cells live, and dopamine production, it can be stimulated when you're shining light coming in from certain areas. So with those glasses, if you're trying to do more dopamine stimulation, you can modify the flashing lights so that they're brighter in the lower visual field, which is going to help improve dopamine stimulation and dopamine production. I think that's right. Yeah, the bottom row of lights, if they're flashing brighter, it'll improve dopamine production. And then with serotonin, if you use those same glasses, and again, this would depend on if you need, they have red ones, purple ones, blue ones, just depends on what your brain works best with. But if you want to improve serotonin production, which helps play a role in lots of things like regulation of sleep, pain perception, body temperature, regulation of autonomic function, blood pressure, and hormonal activity, you can have the lights flashing brighter in the top row. In our clinic, we also do some hemispheric integration. I think these are great for patients who've had a stroke. Stroke is kind of like a clear cut neurological issue where, like, if you've had a right brain stroke, we know, hey, we want to stimulate that right brain. How would we do that? Well, we could give them some eye lights and have them shining in their left visual field to stimulate that right brain region. Let me just let some people in. So I use it for brainstem stimulation. I use it for brain stimulation, and I also use them while we're doing other exercises because they're glasses. They're wearable glasses that are modifiable. You can change all the settings and have light shining in all different directions. The next thing for brainstem stimulation is the tongue. This paper was so neat. I'm not sure if I've shared this. I think I shared it in a short video on my Instagram page, but this is a cool paper. So the majority of research on electrical tongue stimulation is coming from a company that has the PONS device. It's a simple device, but it's really neat. All you're doing is electrically stimulating the top front area of the tongue. But this was cool because this resonates with everything I'm talking about. So I just want to read this to you. It's a little gruesome, but this gentleman here, he's a soldier. His name's Trevor Green. He survived a very severe attack. It was an open TBI in 2006. He was doing daily rehabilitation. And again, this paper is pretty new. It's from 2020. He was doing traditional physical therapy, occupational therapy, speech therapy to recover his motor function, but he plateaued. And what they found was that when they incorporated tongue stimulation to his physical exercises, it helped him break past that plateau. I think, and again, this is just from what I've seen in the clinic, I truly think that the reason he was able to break through his plateau is because they filled in one of the potholes. They smoothed out the foundation that was injured. Because when you do tongue stimulation, sensory on tongue is a lot of facial nerve, which is cranial nerve 7. You're also stimulating the hypoglossal nerve. So you're getting a lot of brainstem stimulation when you're electrically stimulating the tongue, but you're also getting projections from the brainstem to motor areas like the cerebellum and then also the parietal and frontal lobes. So it's really neat. The conclusion showed that it gave them valuable insight on how using electrical stimulation to the tongue can enhance motor recovery and help patients break through plateaus. Another paper that is out there, I don't think I added it in here, was a paper that they have done on MS patients. And what they did was they coupled balance exercises or gait training exercises, so walking exercises, with electrical tongue stimulation, and it helped improve muscle endurance, clinical outcomes, improve gait, improve balance just by stimulating the tongue. But they were co-activating. So they were doing tongue stimulation while they were doing their physical therapy. I think that's so cool. Again, something weird, right? Like the ear, the face, the tongue, but there's so much that happens when you stimulate those areas. It just kind of like lights up the base of the brain, the brainstem. So pretty neat. So we'll do that in the clinic. We use this device. It's called the StimPod. I don't have a PONS device. I've reached out to the company. They're a little bit more expensive than this device here. So I use electrical stimulation to the tongue, but I think it's also important. So a lot of our patients, they have a feeding tube, right? So they're NPO, they're nothing per mouth. You can't put anything in their mouth because they can't swallow, but they can taste. So we use a lot of sensory stimulation to the tongue to help reconnect brain, body, brain, gut, but then also just to stimulate the brainstem. So different tastes on different areas of the tongue. We'll use sweet, salty, sour, favorite taste, just to literally just like a drop of something. Just like put a little food. I recommend like putting a little bit of food on the tip of the tongue so that the patient can taste it, because patients can hear, patients can see, patients can feel, patients can taste. And by doing that, I think you're starting to really stimulate those areas of the brainstem. And again, smoothing out the foundation and filling in the potholes. That's a cool little image I found from this website. I didn't make that. Okay, last but not least are the eyes. There's several cranial nerves that are responsible for visual and then also for eye movements. We've got our oculomotor, which is cranial nerve 3. We've got cranial nerve 4 and cranial nerve 6 that all help with eye movements. I don't necessarily go straight into eye movements though.
Guidance device. We recently started using it in the clinic and I love it. I use it for a couple of different things. What we're going to use it for today in this video, I'm going to show you how to do gaze stability exercises to stimulate the VOR, the vestibulo-ocular reflex. And I like it because it gives the patient a point of reference, and it helps with the actual smoothness of the motion. So on the top of my head, I have a little laser. And with the patient either seated or standing, I'll get the laser squared up so that their head is neutral, and then the laser is pointing at the center dot. And what they want to work on are called yes, yes, no, no exercises. So what that looks like is a head motion up to one dot, and then back down to another dot in a yes, yes head motion. And then we go back to center, and then we go left to right in a no-no fashion. And if you can just look at me so people can see my head. So this is yes, up, down, center, left, right, center. And we'll do a couple of reps of that and a couple of sets. Again, that's to help stimulate the brainstem, the vestibulo-ocular reflex, and help coordinate head and eye movements, which may have been disrupted because of a brain injury or concussion.
So there's lots of ways to do eye exercises. Some patients, they can't do that themselves. That's an active VOR exercise. You can also do passive exercises where you're helping the patient move their head. But just by doing that, you're stimulating what's called the vestibulo-ocular reflex, and you're indirectly engaging those cranial nerves to work, either to activate or inhibit. So I think it's a really important part, again, because 90% of patients who have had a brain injury have visual dysfunction. But this also helps with balance. This helps integrate primitive reflexes because of your head motion, right? Like a yes, yes head motion. You're actually also testing, if their eyes are closed, the TLR primitive reflex. So it's a little bit of a combination of everything, but I'll either have the patient seated or standing. I'll move their head for them, or they'll move their head. This can be a hard exercise for kids, kids who have attention issues. It's not very fun, right? But it also can really, really help. So we use that in the clinic, and I like it. This was created by a physical therapist, so it's a neat little tool. You don't have to have it. You could have some dots on the wall, and you could just have the patient look. But I like having a visual reference for the patient. So that's a bunch of information. Um, what would it look like if you had an hour to work with someone? The way I do it is I try to break up. We usually do therapy in hour sections. I try to break them up in 20-minute chunks. So the first 20-minute chunk, I would focus on that first part, and the first part would be doing vagus nerve stimulation, and that would either be doing some breath work exercises or actual electrical stimulation to the sympaconcha of the ear. I'll usually do a circuit. So if I've got 20 minutes to do vagus and trigeminal nerve stimulation, I'll spend 5 minutes on the sympaconcha, 5 minutes on the trigeminal system, and then same thing on the other side. So that's a total of 20 minutes, right? 5 times 4. Yeah. So that's a total of 20 minutes on vagus nerve and trigeminal nerve stimulation. From there, and again, the goal with that, balance out autonomic function. From there, already knowing what primitive reflexes we need to stimulate, we'll do a little primitive reflex remediation circuit. So we'll do a couple of exercises in a circuit to help stimulate those primitive reflexes. And then from there, either go into doing more cranial nerve work, right? Like doing motion guidance exercises, doing balance exercises with tongue stimulation, doing taste exercises while wearing eyeglass, the eyelights, or you could have them wearing eyelights for the whole hour if you'd like. Or you can end the session with a 20-minute brain tap. So that's what like an hour of therapy would look like if I was to break it up into 20-minute chunks using essentially those three areas that we just talked about. So a couple of key takeaways just to remember. If you're looking at brain injury, if you're trying to help patients recover from brain injury, if you're a practitioner, or if you're a loved one who has someone at home trying to recover from a brain injury, it is my personal belief, just from what I've seen in the clinic, that the brainstem needs attention. And the reason for that is you've got to smooth out the crack in the foundation and fill in the potholes. So the brainstem stimulation is foundational for healing. And you don't have to have a bunch of fancy tools to do it. There's other ways to do it, but there should be a focus on vagus nerve stimulation. There should be a focus on reducing sympathetic activity and improving parasympathetic function. There should also just be a focus on other cranial nerves that you could potentially exercise and stimulate uh, simply. So, yeah, that's that part. And then the second part is I have a saying, I don't know if I came up with this or if I heard it somewhere, but the brain is a sensory sponge. And with brain injury, doing multimodal, so a bunch of different things potentially at once, multimodal sensory integration, it can help improve clinical outcomes. So you want to stimulate different areas of the brainstem, while you're co-activating with potential if you have lasers or red light therapy or if you have eyeglasses. So the more that you can do and the more that the patient can tolerate, the stronger the brain will be. So last but not least, the next one I'm going to talk about is the cerebellum and the vestibular system, and we'll do that next month in March. March is Brain Injury Awareness Month, so we'll be doing that. And thank you so much. I'm hoping for people that are semi-local in April. I know it's kind of short notice, but Dr. Kyle Daigle from our Louisiana office and I were going to put together a beefed up version of these online talks so that like people can do hands-on stuff. So hopefully we'll be posting about that at the end of this week or next week, but it's going to be a 2-day in-person brain injury basics seminar where we just talk about this stuff. So we'd love to have you. If you want more information on that, just shoot me a message on Facebook and I'll do my best to get back to you as soon as I can. Thank you so much for your time and hope everyone has a great day.